Welcome to the Hospital Medicine Unplugged podcast. Today, we are undertaking a really comprehensive deep dive into the source material concerning the management and understanding of acute interstitial nephritis.
Right, we're using a quite robust stack of recent literature here.
Exactly. Alongside some foundational excerpts from Advances in the Management of Acute Interstitial Nephritis to give you, the practicing physician, a really rigorous clinical update.
And as a practicing physician, you are acutely aware that when you're covering the medical wards, acute kidney injury is simply one of the most ubiquitous clinical challenges you face.
Oh, absolutely. You are constantly evaluating fluctuating renal function, right? Often in highly complex, multimorbid patients. And within that daily reality, acute interstitial nephritis represents a significantly underrecognized cause of renal failure.
The stakes for you and your patients are remarkably high here, primarily because the legacy diagnostic frameworks we all memorized in medical school are, well, they're unequivocally failing us in modern clinical practice.
Failing us completely. I mean, for decades, medical education heavily emphasized a very specific phenotype. We all know it.
The classic triad.
Right, the classic triad of fever, rash, and peripheral eosinophils. But relying on that outdated paradigm actively harms patients.
It really does.
It leads to delayed diagnoses, irreversible structural renal damage, and ultimately profoundly poorer patient outcomes.
Which is why our mission today is to systematically deconstruct those legacy concepts. We need to rebuild your clinical approach to this disease using the most current evidence-based data available.
Focusing heavily on modern diagnostics, the biomarker revolution, and the highly specific nuances of corticosteroid timing.
That is precisely the clinical imperative we face today. The cognitive baggage of that classic triad is something we have to actively unlearn when we examine the true burden of this disease through the lens of recent epidemiological data. The absolute necessity for a high index of suspicion becomes undeniably clear.
Let's look at the raw numbers from the source material. It indicates that acute interstitial nephritis accounts for 15 to 27% of all renal biopsies performed specifically for acute kidney injury.
Let's just pause on that figure for a moment. Up to 27%.
Yeah.
That means in a quarter of the cases where a nephrologist feels an AKI is severe or mysterious enough to warrant a tissue diagnosis, they're finding an active interstitial inflammatory process.
That is a staggering proportion. But I do want to challenge how we interpret that data on the wards, because we know there is an inherent selection bias in biopsy data.
Absolutely, there always is.
If we contextualize this within the broader landscape of nephrology, the literature notes that this disease represents 2.8% of all kidney biopsies performed for any indication whatsoever.
Right, but as you mentioned, when the clinical scenario narrows specifically to acute renal failure, that figure escalates dramatically to 13.5%. and even higher in specific AKI cohorts.
Furthermore, when we isolate drug-induced etiologies, which is frankly the predominant form we encounter in the hospital setting, it occurs in 0.5 to 3% of all kidney biopsies globally.
However, it jumps to 5 to 27% of biopsies performed specifically for AKI.
So the question is, how do we translate those biopsy statistics into the reality of a busy medical admission unit where we are not biopsying every elevated creatinine?
You're highlighting the exact translational gap the literature attempts to bridge. Those numbers are not just statistical artifacts. They represent a massive, often invisible cohort of patients in your daily practice whose renal function is actively deteriorating.
Deteriorating due to a misidentified inflammatory process.
Precisely. Rather than simple hypovolemia or acute tubular necrosis, which is what we usually assume, the reason those biopsy numbers range so widely from 5 up to 27% is heavily dependent on the demographic being studied and the threshold for actually performing the biopsy.
Which brings us to a critical demographic shift highlighted in the data.
Yes. The incidence of this condition is steadily increasing, and this trend is particularly pronounced in the elderly population.
The aging demographic presents a really unique set of challenges. When you admit an 82-year-old patient with an unexplained rise in their serum creatinine, the clinical picture is rarely straightforward.
Almost never.
The sources point to specific clinical reasons driving this demographic shift, and the first is polypharmacy.
Polypharmacy is rampant among older adults. It inherently complicates the identification of the single offending immunologic trigger.
I mean, when a patient is admitted on a dozen medications, pinpointing the exact agent requires a meticulous chronological mapping of their pharmacological history. You are looking for a needle in a haystack of antihypertensives, supplements, and prophylactic antimicrobials.
Exactly. And the second major factor driving this trend is the well-documented underutilization of kidney biopsies in older populations.
Sure. Clinicians are inherently and often justifiably hesitant to subject frail elderly patients to invasive procedures.
They may have a coagulopathy, they may be uncooperative, or their solitary functioning kidney makes the risk profile unacceptable.
Right.
Because we avoid the biopsy, we are undoubtedly underestimating the true prevalence of the disease in this demographic. As the treating physician, you are frequently forced to make a presumptive diagnosis based entirely on clinical acumen and epidemiological probabilities.
This means understanding the precise etiologies, the actual culprits driving this information, is simply non-negotiable.
So let's examine those culprits.
The literature is unequivocal on this point. Drugs account for 70 to 90% of biopsy-proven cases. But before we look at the specific agents, I found the geographic disparity in the data quite striking.
It is. The prevalence of a drug-induced etiology ranges from 50% in less developed countries to 78% in more developed countries.
That tells us that our highly medicalized, heavily prescribed healthcare environment is actively generating this pathology. In our practice environment, when you see unexplained tubulo-interstitial inflammation, you must assume a drug-induced etiology until proven otherwise.
That geographic discrepancy is largely a reflection of medication access, outpatient prescribing patterns, and conversely, the baseline prevalence of infectious or environmental nephrotoxins in less developed regions.
Absolutely.
But focusing on our clinical environment, you need a highly specific understanding of the most common offenders to effectively manage these cases. The data precisely delineates the top 3 individual drugs responsible for the disease.
Let's list them. Omeprazole accounts for 12%. Amoxicillin accounts for 8%, and ciprofloxacin accounts for 8%.
We need to dissect that top tier carefully because those 3 drugs alone account for over a quarter of all cases. When we look at medication classes broadly, antibiotics remain the most common class overall, responsible for 49% of drug-induced cases.
Within this class, you must maintain a high index of suspicion for penicillins, cephalosporins, rifampin, and fluoroquinolones.
If a patient is admitted for a COPD exacerbation or a suspected urinary tract infection, they're almost certainly receiving one of those agents.
Right, and if their creatinine starts creeping up on day 4 of admission, the cognitive reflex is often to blame the underlying infection or a subtle hemodynamic shift.
The data demands that we pivot to suspecting the antimicrobial agent itself. But as significant as the antibiotics are, the data regarding proton pump inhibitors warrants an even deeper exploration.
The PPI data represents a fundamental shift in our understanding of this disease. Proton pump inhibitors account for 14% of drug-induced cases overall.
And as you noted, omeprazole alone is the single most common drug, representing 12% of all cases globally.
The source material emphasizes that PPIs are emerging as an increasingly dominant contributor, especially in the elderly demographic we just discussed.
The dominance of omeprazole and the PPI class cannot be overstated, and it requires a complete overhaul of how you review medication reconciliation upon patient admission.
The real challenge with PPIs is how invisible they have become in our daily practice.
They blend into the background.
Exactly. Unlike intravenous antibiotics, which have clearly defined start and stop dates meticulously documented in the inpatient electronic medical record, PPIs are entirely different. They are frequently initiated in the outpatient setting, often without a clear, ongoing, evidence-based indication.
And crucially, they are available over the counter. When you take an admission history, patients may not even consider their daily omeprazole a prescription medication.
They view it in the same category as a multivitamin.
That lack of recognition is dangerous because the onset of PPI-induced inflammation is notably insidious. It does not typically present with the acute, explosive, symptomatic hypersensitivity reactions we historically associated with beta-lactam antibiotics.
The patient simply experiences a slow, asymptomatic decline in their estimated glomerular filtration rate.
Beyond antibiotics and PPIs, your differential must absolutely include NSAIDs, which account for 11% of drug-induced cases.
Similar to PPIs, the widespread over-the-counter availability of NSAIDs means you must proactively interrogate the patient regarding their use.
But we must also rigorously evaluate the patient's exposure to 5-aminosalicylates like mesalamine, which we frequently see in our inflammatory bowel disease populations.
Additionally, the list includes allopurinol, various diuretics with a particular emphasis on thiazides, H2 receptor antagonists, and phenytoin alongside other anti-seizure medications.
But the pharmacological landscape is constantly evolving, and the literature explicitly cites new culprits coming to the forefront. Chemotherapeutic agents are highlighted as a significantly under-recognized cause.
The oncology intersection is arguably the most rapidly evolving area of nephrology right now. Specifically, immune checkpoint inhibitor-associated tubulointerstitial inflammation is highlighted as an increasingly critical etiology.
Given the widespread and expanding use of these targeted therapies across multiple oncology protocols, from melanoma to non-small cell lung cancer, you are guaranteed to encounter these patients on the medical wards.
You really have to understand the mechanism of action here. Immune checkpoint inhibitors, such as PD-1 or CTLA-4 inhibitors, essentially remove the brakes on the immune system to allow T cells to attack the malignancy.
But by breaking that immune tolerance, you inherently predispose the patient to severe autoimmune-like toxicities.
Right. The renal parenchyma, specifically the tubulointerstitial compartment, is highly susceptible to this unleashed T cell activity.
That mechanism explains why the presentation can be so severe in the oncology population. While drug-induced causes absolutely dominate the epidemiological landscape, your differential diagnosis must remain comprehensive.
If you anchor entirely on medications, you will miss the non-drug etiologies. The sources require us to keep several distinct syndromes on the differential.
You must consider tubulointerstitial nephritis with uveitis, or TINU syndrome. You must evaluate for IgG4-related disease, which can present with mass-like lesions in the kidney alongside the diffuse inflammation.
You must keep drug reaction with eosinophilia and systemic symptoms, the G-DRESS syndrome, in mind. Sarcoidosis is another classic non-drug etiology.
Finally, ANCA-associated vasculitis should be considered, though the literature specifically notes that isolated interstitial inflammation is a remarkably rare presentation for ANCA vasculitis, which typically heavily involves the glomeruli.
Maintaining that broad differential is essential, not just for academic completeness, but because the underlying pathophysiology dictates vastly different systemic management strategies.
Treating an acute omeprazole reaction is entirely different from managing systemic IgG4-related disease.
This seamlessly brings us to the underlying pathophysiology and histopathology. Understanding the cellular mechanisms is not just a basic science exercise. It is paramount to understanding the profound clinical urgency of treatment.
The immunologic mechanisms driving this disease are predominantly characterized by dual pathways. Historically, our models focused almost exclusively on the major pathogenic role of cell-mediated immunity.
Specifically, a type IV delayed hypersensitivity reaction involving robust T-cell activation.
We see that type 5e mechanism frequently, but the current source material highlights emerging evidence that complicates the picture. There is now recognition of IgE-mediated mast cell activation, representing a type I hypersensitivity component operating alongside or independent of the cell-mediated pathway.
This explains some of the heterogeneity we see in clinical presentations. Regardless of whether it is a type I or type 5e mechanism, the core pathogenesis involves a complex immunologic reaction.
The immune system mounts an attack directed either against endogenous nephritogenic antigens or against exogenous antigens such as drug metabolites that have been processed and presented by the tubular epithelial cells themselves.
That concept of the tubular epithelial cell acting as an antigen-presenting cell is the ignition switch for the entire inflammatory cascade. The drug metabolite binds to the tubular basement membrane, altering its immunogenicity.
The immune system no longer recognizes the tubule as self.
For you as the treating physician, the most critical pathophysiological concept to grasp from the literature is the concept of the critical window. When that immune reaction triggers, a dense cellular infiltrate floods the renal parenchyma.
But those inflammatory cells do not remain benignly in the interstitium. They experience a rapid, aggressive transformation into areas of interstitial fibrosis.
This is the biological race against time that you are running every single time you review a morning metabolic panel. The cellular infiltrate actively orchestrates a fibrogenic response. It stimulates fibroblasts to deposit dense extracellular matrix.
That matrix physically strangles the delicate tubules and irreversibly destroys the intricate renal architecture.
This rapid progression from active, potentially reversible cellular inflammation to permanent acellular fibrosis is the exact biological reason why early treatment is absolutely critical. Once that fibrosis is firmly established, the structural damage is permanent,
regardless of how aggressively you deploy therapeutic interventions later.
To truly appreciate the speed and severity of this transformation, we must walk through what the pathologist actually visualizes on a classic biopsy report.
If you secure a tissue sample early in the disease process, the hallmark finding is an interstitial inflammatory infiltrate predominantly composed of lymphocytes and monocytes alongside macrophages.
This directly aligns with the type 4V cell-mediated hypersensitivity mechanism we just discussed. The T cells are actively swarming the interstitium.
Now, we must use this histological reality to clarify a very common, highly pervasive, and genuinely dangerous clinical misconception.
You are referring to the legacy fixation on eosinophils.
I am.
We have to be definitive about this. Peripheral and tissue eosinophils are actually present in only a minority of cases. For decades, board examinations and attending rounds trained physicians to look for them as the hallmark of this disease.
The modern histopathological data proves that while their presence in the tissue can be supportive of an allergic drug reaction, their absence means absolutely nothing in ruling out the diagnosis.
If you are waiting for a pathologist to call you with a report of dense eosinophilic infiltrates before you initiate therapy, you are allowing that critical window to close.
That is precisely the danger. The biopsy will frequently demonstrate other key features that explain the clinical presentation. The pathologist will note plasma cells and severe interstitial edema.
That edema is mechanically significant. It physically separates the tubules, increasing intrarenal pressure and directly contributing to the acute decline in the glomerular filtration rate.
As those inflammatory cells aggregate in the interstitium, they do not just remain passively in the extracellular space. The biopsy report will frequently describe active tubulitis.
Tubulitis is a critical term for the clinician to understand. It represents the active, destructive invasion of the tubular epithelium by these inflammatory cells. The lymphocytes cross the tubular basement membrane and directly attack the epithelial cells.
This direct cellular assault leads to widespread tubular cell death, desquamation, and profound tubular dysfunction.
In more advanced cases, specifically those where the diagnosis was delayed by weeks because the clinician assumed the patient simply had acute tubular necrosis, the pathologist will report a very different landscape.
They will report tubular atrophy and established interstitial fibrosis.
The source material strictly notes that the degree of interstitial fibrosis observed on the biopsy correlates directly and powerfully with chronicity and a poor prognosis for long-term renal recovery.
When you read moderate to severe interstitial fibrosis on a pathology report, you are reading the description of permanent chronic kidney disease.
It is also important for the clinician to note what is generally absent on these reports.
The glomeruli are typically normal or only minimally affected by the surrounding interstitial chaos.
This is a vital diagnostic discriminator, helping you distinguish this tubulo-interstitial entity from an active glomerulonephritis, which would require a drastically different immunosuppressive regimen.
There are also special histologic variants discussed in the literature that you should be aware of as they point towards specific underlying etiologies.
The literature describes granulomatous variants, where the macrophages form distinct granulomas within the interstitium. This specific histological pattern is highly associated with medications like hydrochlorothiazide, furosemide, and allopurinol, as well as non-drug causes like sarcoidosis or mycobacterial infections.
Additionally, there is a variant known as IgM-positive plasma cell tubulointerstitial nephritis. This is a highly specific variant strongly associated with distinct clinical syndromes, namely distal renal tubular acidosis and Fanconi syndrome.
Understanding these profound histological realities, the shift from active tubulitis to irreversible fibrosis, and the general absence of eosinophils is what empowers you to completely rethink the clinical manifestations and your diagnostic approach on the wards.
We must definitively dismantle the legacy teaching surrounding the classic presentation. We touched on this in the introduction, but the data requires us to be absolute.
The classic triad of fever, rash, and peripheral eosinophils, often referred to as eosinophilia, is a clinical anachronism.
It is worse than an anachronism. It is a cognitive trap. The modern, rigorous epidemiological data demonstrates that this complete triad occurs in less than 10 to 15% of modern cases.
Let that sink in. If your clinical threshold for suspecting this disease requires a patient to develop a fever, a maculopapular rash, and a significantly elevated peripheral eosinophil count, you will entirely miss the diagnosis in 85 to 90% of your patients.
You cannot practice modern medicine relying on a diagnostic heuristic with a 15% sensitivity.
You cannot. And the modern clinical reality you face is far more subtle and significantly more challenging. Most patients do not present with an explosive systemic allergy.
They present with oligosymptomatic or entirely nonspecific complaints. They will report days or weeks of general malaise, mild nausea, and perhaps some vomiting. They might report fatigue.
These are symptoms that overlap with countless other conditions in the hospitalized patient, from a mild viral illness to early heart failure. This vast overlap requires you to maintain an exceptionally high index of suspicion when evaluating any unexplained acute kidney injury.
When we examine the specific renal findings, the presentation is typically that of a non-oliguric acute kidney injury. This is a crucial physiological distinction.
Unlike ischemic acute tubular necrosis, where the tubules obstruct and urine output often drops precipitously into oliguria or anuria, patients with active interstitial inflammation may maintain completely normal or even elevated urine volumes.
They are still producing urine, but the severely damaged tubules cannot regulate solute clearance.
You will see a rapidly rising serum creatinine alongside seemingly reassuring urine output. This discordant clinical picture often lulls the unwary physician into a false sense of security.
That false security is deadly for the nephrons. Furthermore, because the primary site of injury is the tubule and not the glomerulus, the urinalysis presents specific patterns. Tubular, non-nephrotic range proteinuria is usually present.
The source material highlights a crucial chronological detail regarding this tubular dysfunction. The functional deficits of the tubules often precede the measurable decrements in the glomerular filtration rate.
This chronological detail provides a massive advantage if you know what to look for. It means that if you are monitoring specific markers of tubular handling, you could detect the inflammatory process before the serum creatinine visibly spikes.
You might observe unexpected glycosuria in a non-diabetic patient, or aminoaciduria, or a sudden, unexplained inability to concentrate the urine resulting in polyuria.
These are the distress signals of a failing tubule. Detecting them requires a rigorous, thoughtful evaluation of the urinalysis, which leads us to another necessary, definitive update in our diagnostic practice.
The urinalysis is universally the first line of investigation for acute kidney injury. But we must correct another severely outdated practice regarding its interpretation.
Historically, testing for eosinophiluria, ordering a urine stain for eosinophils, was heavily emphasized as a primary diagnostic tool. It was considered the non-invasive gold standard.
However, the current literature is definitive and uncompromising. Eosinophiluria is neither sensitive nor specific for this disease.
We need to strike this from our order sets. I know this has been a board exam staple, and there is a deep-seated reflex to order it when a drug reaction is suspected.
But the evidence shows its presence does not confirm the diagnosis, as it can be seen in atheroembolic disease, rapidly progressive glomerulonephritis, and even severe urinary tract infections.
Conversely, and more dangerously, its absence certainly does not rule the disease out. Relying on urinary eosinophils to guide your management can lead to catastrophic diagnostic delays.
Instead of hunting for useless markers, the literature emphasizes that the presence of white blood cell casts in the urinary sediment is a much more specific, actionable finding.
When you look under the microscope and see white blood cell casts, you are visually confirming the direct consequence of the tubulitis we discussed during the histopathology section.
You're seeing the actual inflammatory cells, the lymphocytes and monocytes that have actively extruded into the tubular lumen, aggregated with TAM-Horsfall protein, and taken the physical shape of the dying tubule.
When you see a white blood cell cast in the setting of acute kidney injury, this disease must immediately elevate to the very top of your differential diagnosis.
The reality is that recognizing white blood cell casts requires a good microscope and a skilled observer, which are not always immediately available.
The limitations of traditional diagnostics like the standard urinalysis, coupled with the highly invasive nature of renal biopsies, highlight a massive clinical challenge on the wards.
Biopsies are not benign. They carry bleeding risks, they are frequently delayed due to logistical scheduling issues over weekends, or they are contraindicated by patient factors like thrombocytopenia or coagulopathy.
And in the frail elderly, as we noted extensively, they are frequently avoided altogether.
This massive diagnostic void creates a desperate need for highly accurate, non-invasive tools. This brings us to what the source material appropriately describes as the biomarker revolution, with a specific, intense focus on urinary CXCL9.
The emergence of urinary CXCL9 is arguably the most significant advancement in the non-invasive management of this condition. You need to understand the underlying science behind this star biomarker to appreciate its utility.
CXCL9, which stands for CXC motif chemokine ligand 9, is an interferon gamma-induced chemokine.
Its primary biological function in the immune system is to mediate lymphocyte chemotaxis.
Let us break that mechanism down for the listener. Essentially, CXCL9 is the specific chemical distress signal secreted by the cells in the kidney to recruit T cells into the renal interstitium during that initial type 5 cell-mediated hypersensitivity reaction.
It is the molecular beacon drawing the destructive lymphocytes into the tissue.
Because CXCL9 is directly, mechanistically involved in the pathogenesis of the cellular infiltrate, measuring its presence and concentration in the urine provides a direct, real-time, non-invasive window into the inflammatory activity currently raging within the kidney.
Precisely. You are measuring the precise signal causing the damage. The data supporting its clinical use is stunning.
The source material states that urinary CXCL9 levels were found to be 7.6-fold higher in patients with biopsy-proven disease compared to control populations.
The 7.6-fold increase is a massive, unmistakable diagnostic signal. When subjected to rigorous validation cohorts to test its true diagnostic accuracy, urinary CXCL9 demonstrated an area under the curve, or AUC, of 0.94.
For those of you evaluating clinical trials, an AUC of 0.94 is exceptional. It represents a degree of diagnostic accuracy that far surpasses almost any of our traditional clinical or laboratory markers for renal disease.
It means the test is highly capable of distinguishing between a patient with active interstitial inflammation and a patient with another cause of kidney injury.
Furthermore, the literature highlights its specific utility in the complex oncology patients we discussed earlier. In challenging cases of immune checkpoint inhibitor-associated injury, where distinguishing between autoimmune toxicity and hemodynamic ATN is incredibly difficult, CXCL9 demonstrated an AUC of 0.84.
That 0.84 AUC in the oncology cohort is a game changer for the treating oncologist and nephrologist, as it directly informs the perilous decision of whether to permanently discontinue a life-saving cancer therapy and initiate high-dose immunosuppression.
The practical application of this biomarker is already being refined for routine clinical use. The literature outlines that utilizing a CXCL9 to creatinine ratio demonstrates high sensitivity and specificity.
By creating a ratio with urinary creatinine, you correct for normal physiological variations in urine concentration, providing a stable, reliable metric that allows for the establishment of well-defined clinical thresholds.
While CXCL9 is clearly the star of this emerging field, there are other biomarkers currently under active investigation that you will likely see entering clinical practice soon.
The sources review urinary TNF-alpha and IL-9, which are critical cytokines that reflect T-cell polarization and the overall intensity of the inflammatory milieu.
Additionally, there is urinary kidney injury molecule 1, or KIM1. KIM1 serves as a highly sensitive marker of direct structural tubular injury.
Finally, urinary soluble C5b9 has been identified as a robust marker of interstitial inflammation and complement activation.
The research indicates that combining these specific markers can yield incredibly powerful diagnostic panels. For example, the literature notes that the combination of KIM1 and soluble C5b9 has an AUC of 0.864 for detecting acute tissue injuries, specifically in this setting.
The development and validation of these non-invasive biomarkers is not merely an academic exercise designed to generate publications. It is an urgent, absolute clinical necessity.
The entire fundamental purpose of securing an early, highly accurate diagnosis, whether through a biopsy or an advanced biomarker, is to allow you to initiate treatment before that critical window closes.
You must act before the cellular infiltrate transforms into irreversible interstitial fibrosis. This brings us to the core of management, specifically the profound nuances of corticosteroid therapy.
The decision to initiate corticosteroids is one of the most consequential decisions you will make for these patients. But we must first acknowledge a significant, often frustrating gap in the foundational literature.
There are currently no randomized controlled trials that have definitively, prospectively tested corticosteroid efficacy in this specific disease state.
Because of this lack of level 1 evidence, historical practice has not uniformly supported their use. And if you look at older retrospective studies, you will find considerable heterogeneity in both methodology and outcomes.
The lack of RCTs has historically fueled clinical inertia. However, you cannot let the absence of perfect data paralyze you while the patient's kidneys fibrose.
The source material specifically highlights a comprehensive 2025 systematic review and meta-analysis, which aggregated the best available observational and retrospective data.
This modern analysis clearly demonstrated that prednisolone use significantly improved long-term renal outcomes in these patients compared to conservative management alone.
The decision to use steroids is only the first step. The true clinical nuance, the factor that actually dictates your patient's renal survival, lies in the timeline of administration.
We must spend extensive time dissecting this timeline because it is the most actionable piece of data in the entire deep dive into the source material.
The data is resoundingly clear. Early steroid administration, which is strictly defined in the literature as initiation within 7 days after diagnosis, improves the trajectory of renal function recovery and significantly decreases the long-term risk of chronic renal impairment.
To understand the power of that early intervention, you must contrast it with the dismal outcomes of delayed treatment. The literature notes that delayed steroid treatment, defined in the major studies by an average initiation at 34 days, results in profoundly incomplete recovery when compared to treatment initiated within the first 2 weeks.
The source material stresses this point emphatically, almost aggressively. A delay in steroid initiation directly and linearly correlates with the patient's final baseline serum creatinine level and the pathological progression of interstitial fibrosis seen on follow-up biopsies.
Every day you wait, nephrons are dying. This creates a highly specific, non-negotiable clinical action point for you on the wards.
If you suspect drug-induced interstitial inflammation, the absolute first step is the immediate, permanent cessation of the suspected offending agent.
But you cannot simply withdraw the drug and wait indefinitely to see if the kidneys magically recover on their own.
Corticosteroids should be initiated if there is no clinical evidence of kidney function recovery after 5 to 7 days of withdrawing the offending drug.
That 5 to 7 day window is your observational limit. If the serum creatinine remains elevated, or worse, continues to climb relentlessly after that 5 to 7 day period of drug withdrawal, it means the immunologic cascade is no longer dependent on the presence of the drug antigen.
The inflammation has become self-propagating, and you must intervene pharmacologically to shut it down.
We must also critically discuss the duration and dosing of this therapy, because in the realm of immunosuppression, more is absolutely not better.
The source is explicitly warned against prolonged therapy. The data shows that high-dose corticosteroid treatment maintained for 3 weeks, or any prolonged treatment course extending over 8 weeks in total, were not associated with any greater probability of kidney function recovery.
In fact, prolonged courses simply expose the patient to the myriad devastating morbidities associated with chronic steroids.
You are trading potential renal benefit for guaranteed iatrogenic harm. If you leave an elderly patient on high-dose steroids for months, you will induce profound immunosuppression, severe hyperglycemia, proximal myopathy, and rapid bone loss, all without conferring a single additional nephron of functional recovery.
Therefore, you must adhere strictly to the typical evidence-based regimen. The recommended starting dose is prednisone at 0.8 plus or minus 0.2 milligrams per kilogram per day.
For the average adult, this generally equates to a manageable 40 to 60 milligrams daily.
The total treatment duration, which encompasses both the initial high-dose phase and the subsequent gradual taper, ranged from 1.5 to 12 weeks in most of the reviewed studies.
It is designed to be a targeted, overwhelming strike to suppress the acute cellular inflammation, followed by a systematic, controlled withdrawal.
But what happens when standard therapy fails? In cases where patients are either inherently intolerant to high-dose corticosteroids or their disease proves stubbornly refractory to the initial steroid course, the literature mentions alternative therapies.
Specifically, mycophenolate mofetil is highlighted as an evaluation option for these challenging steroid-refractory patients. Mycophenolate provides a fundamentally different mechanism of immunosuppression, targeting lymphocyte proliferation to halt the cell-mediated tissue damage.
With the complex management strategy clearly defined, we must rigorously analyze the prognosis. You need to know exactly what to tell your patients and their families regarding their short-term gains and the stark realities of their long-term outcomes.
Let us first break down the outcomes for short-term recovery, which is typically evaluated at the 6-month mark. For patients with drug-induced etiologies who are appropriately treated with steroids, the statistics are as follows. 49% achieve complete recovery of their renal function, returning to their pre-insult baseline.
While 49% complete recovery is encouraging, we must look at the rest of the cohort. 39% achieve only partial recovery.
This means that while their serum creatinine improves from its peak, it remains permanently elevated above their pre-insult baseline. They are left with some degree of chronic kidney disease.
Unfortunately, 12% experience absolutely no recovery whatsoever. Their renal function is permanently destroyed by the acute event.
When combining the complete and partial response groups, overall, 76% of patients achieve some form of measurable kidney recovery within 6 months.
While a 76% overall response rate sounds initially promising, it necessitates a brutal look at the chronic consequences for those who do not fully recover, and for those who present with different non-drug etiologies.
The long-term outcomes reveal the true devastating severity of this disease and the constantly looming threat of end-stage renal disease.
The data indicates that a significantly decreased estimated glomerular filtration rate, specifically defined as an eGFR of less than 60 milliliters per minute per 1.73 square meters at 12 months, occurs in 47% of patients with drug-induced cases.
That statistic is alarming. It means nearly half of all patients who suffer a drug-induced episode are left with permanent stage 3 or worse chronic kidney disease. And the numbers are significantly worse for the non-drug etiologies we discussed earlier.
A decreased eGFR at 12 months is seen in 74% of patients with TINU syndrome and 57% of patients with other underlying autoimmune diseases.
When we extrapolate this data further out, the analysis shows that progression to true end-stage renal disease develops in 39.4% of patients during a mean follow-up period of 76.5 months.
Nearly 40% progressing to dialysis or transplant within 6.5 years is a catastrophic statistic. It mandates a complete shift in how you view these patients at discharge.
You cannot simply prescribe the steroid taper, discharge them from the hospital, and assume the problem is resolved. They require meticulous, indefinite, long-term nephrology follow-up to manage the sequelae of their newly acquired chronic kidney disease.
To put that massive risk into perspective, the source material compares the prognosis of this inflammatory disease directly to acute tubular necrosis, or ATN.
The comparison to ATN is highly instructive. We often view severe ATN as the worst-case scenario for an AKI, but the data shows otherwise. Acute interstitial nephritis demonstrates a significantly higher rate of non-recovery at 6 months than ATN.
Specifically, 69.4% of these inflammatory patients exhibit non-recovery compared to 49.3% of ATN patients.
The physiological reality is that the structural damage inflicted by destructive tubulitis and the subsequent fibrotic scarring is simply much harder for the kidney to repair than standard ischemic or toxic tubular injury.
The profound magnitude of that ESRD risk is quantified by a hazard ratio of 23.05 when compared to matched control populations.
A hazard ratio of 23.05 is an astronomical figure in medical statistics. It means a patient who survives an episode of this disease is over 23 times more likely to eventually require hemodialysis or a renal transplant compared to someone who never had the disease.
Given these incredibly severe outcomes, you must be hyper-vigilant in identifying the risk factors for poor recovery upon initial presentation.
The variables you must watch for dictate how aggressively you counsel the patient. The first is a longer duration of drug exposure prior to diagnosis.
The data is highly precise here. Complete recovery, partial recovery, and no recovery directly correlated with median drug exposures of 15 days, 30 days, and 130 days, respectively.
The longer the antigen is present, the more entrenched the inflammation becomes. The delay in starting steroid therapy is another major, completely modifiable risk factor.
The exact same progression from complete to partial to no recovery correlated with delays of 8 days, 11 days, and 35 days before steroid initiation.
Those numbers perfectly validate the 5 to 7 day rule we established earlier. Other significant independent prognostic indicators include the presence of moderate to severe interstitial fibrosis and tubular atrophy on the initial diagnostic biopsy.
The requirement for dialysis during the acute phase of the illness is also a major negative predictor. Patient demographics play a role as well. Older patient age and female gender are associated with worse outcomes.
Finally, underlying baseline hypertension, which already strains the renal microvasculature, and any episodes of recurrent kidney injury significantly reduce the probability of the patient regaining their baseline renal function.
Before we move off prognosis, we absolutely must revisit the PPI-induced phenotype, as the literature specifically designates it as a distinct, highly problematic clinical entity.
The PPI-induced phenotype is unique and requires special attention from the treating physician, largely because it violates our typical expectations of how a drug reaction should behave. As we discussed during the etiology section, its clinical characteristics are incredibly insidious.
Because of that insidious onset, patients experience a significantly longer duration of drug exposure before the correct diagnosis is finally suspected and the drug is stopped.
When they finally present to medical attention, they typically have statistically less severe acute kidney injury compared to those presenting with an explosive antibiotic-induced reaction.
However, and this is the critical clinical paradox you must internalize, despite having a much milder initial rise in creatinine, they are ironically far less likely to achieve meaningful recovery by the 6-month mark.
It is a devastating paradox. They present with milder disease, but suffer worse long-term outcomes. The reasons are multifaceted.
These patients are generally older, which, as we just noted, is an independent risk factor for poor recovery. They have a much less symptomatic presentation, meaning they don't seek care immediately.
And crucially, because the drug is often continued for weeks or even months, while the subtle, slow rise in creatinine is investigated, or worse, simply attributed to age-related decline or chronic dehydration, the interstitial fibrosis has ample time to firmly, irreversibly establish itself.
Finally, regarding long-term prognosis, you must be acutely aware of recurrence rates. The likelihood of the disease returning heavily depends on the initial etiology.
Recurrence is observed in a staggering 51% of patients with TINU syndrome and 53% of patients with autoimmune disease-related etiologies. These are chronic systemic issues that require long-term immunosuppressive management.
Conversely, recurrence is only observed in roughly 8% of patients with drug-induced disease, provided, and this is a massive caveat, the offending agent is rapidly identified, permanently removed, and meticulously documented in the electronic medical record as a severe, life-threatening allergy.
As we transition into the final phase of our analysis, we must examine the emerging paradigms in research that will inevitably shape your future practice. The source material outlines new clinical entities that are fundamentally redefining how we categorize and treat this disease.
First, there's the formal recognition of corticodependent relapsing disease. This is a newly identified, highly frustrating entity that poses major therapeutic challenges on the wards.
These are the clinical nightmares. These are the patients who respond beautifully to the initial high-dose course of prednisone. Their creatinine normalizes, and you feel you have achieved a clinical victory.
But the moment the steroid dose is tapered below a certain critical threshold, the tubular interstitial inflammation violently reignites. Their creatinine rapidly climbs again, and the white blood cell casts return to the urinary sediment.
Managing this newly recognized phenotype requires complex, long-term, steroid-sparing immunosuppressive strategies that must delicately balance the prevention of ESRD against the profound risks of chronic systemic immunosuppression.
Another critical emerging entity the literature highlights is autoimmune-related disease that mimics drug reactions. This condition is particularly treacherous because it is frequently misdiagnosed initially as a standard, run-of-the-mill drug-induced case.
The key distinguishing feature here is chronological. These patients may present with classic systemic autoimmune manifestations only after the initial acute kidney injury has been managed and the steroids have been tapered.
This represents a massive diagnostic blind spot. You might successfully treat what you confidently assume is an omeprazole-induced injury. The patient recovers, and they go home.
But months later, they develop severe uveitis, new-onset joint involvement, or test positive for highly specific autoantibodies.
The source material stresses that this phenomenon is exactly why scheduled, rigorous outpatient nephrology and rheumatology follow-up is critical for defining the exact ultimate etiology over time. A single brief hospital admission is almost always insufficient to fully characterize the underlying complex immunopathology.
Looking toward the immediate future of diagnostics and treatment, the literature is heavily focused on creating robust diagnostic models. These models aim to combine currently available clinical tests to massively improve diagnostic accuracy without forcing the patient to undergo a risky biopsy.
By statistically integrating the patient's pharmacological history, specific advanced urinalysis findings, and emerging biomarkers like the CXCL9 to creatinine ratio into sophisticated algorithmic models, researchers aim to provide clinicians with a highly predictive, non-invasive diagnostic score.
Concurrently, there is intense, active research into new advanced imaging markers. We rely heavily on the pathologist's eyes right now, but advanced radiological techniques, such as specific functional MRI protocols or novel PE tracers, may soon be able to directly visualize and quantify the exact degree of active interstitial inflammation versus established irreversible fibrosis.
This would profoundly guide both the initial diagnosis and the incredibly weighty decision to initiate or entirely withhold toxic immunosuppression.
The data also highlights a fascinating point regarding physician intuition. The literature clearly shows that a pre-biopsy clinical diagnosis, meaning the attending physician formally suspected the disease before the tissue confirmed, it is positively independently associated with subsequent kidney recovery.
This powerfully validates the absolute importance of your clinical suspicion. Physicians who recognize the subtle signs early, who suspect the diagnosis despite the absence of the classic triad, trigger much faster therapeutic interventions.
It proves that despite all our advanced technology, astute clinical acumen remains a profound, irreplaceable determinant of patient survival.
Ultimately, the most transformative and exciting area of emerging research lies in unraveling the profound immune heterogeneity of this condition. We are rapidly moving away from viewing this disease as a monolithic, uniform cellular response.
The sources indicate a rapidly growing understanding of diverse, distinct inflammatory endotypes. Specifically, researchers are successfully differentiating between T helper 1 or Th1-driven cellular responses and T helper 2 or Th2-driven immune responses.
This is the dawn of true precision medicine in nephrology. Understanding these highly specific cytokine profiles and cellular pathways at the individual patient level will eventually enable us to abandon our current blunt instruments.
Rather than utilizing broad, highly toxic systemic immunosuppression with corticosteroids for every single patient, we may soon be able to deploy highly targeted biologic therapies.
These biologics would intercept the precise, unique inflammatory signal driving a specific patient's interstitial damage, maximizing therapeutic efficacy while minimizing collateral systemic toxicity.
That brings us to the summary of our deep dive into the source material. For the clinician operating on the wards today, the main takeaways are clear, immediate, and highly actionable. You must categorically, permanently abandon the search for the classic triad of fever, rash, and eosinophils, as relying on it will cause you to miss the vast majority of cases and doom your patients to permanent renal failure.
You must maintain a relentless, almost paranoid index of suspicion, specifically for elderly patients presenting with unexplained acute kidney injury who are quietly taking over-the-counter proton pump inhibitors.
Where your institutional availability permits, you should aggressively advocate for and utilize emerging, highly accurate, non-invasive markers like the urinary CXCL9 to creatinine ratio.
And most importantly, if you suspect a drug-induced etiology and withdraw the offending agent, you must act decisively. Initiate early corticosteroid therapy if 5 to 7 days of drug withdrawal yields absolutely no clinical improvement in the serum creatinine.
Time is quite literally functioning renal tissue, and delaying therapy simply guarantees the rapid progression of irreversible interstitial fibrosis.
The clinical evidence mandates this aggressive, hyper-observant posture. The insidious transition from a reversible acute cellular infiltrate to permanent chronic fibrotic scarring happens in a matter of days to a few short weeks.
Your individual ability to intersect that aggressive pathophysiology with accurate modern diagnostics and timely steroid administration is frequently the sole variable determining whether that patient spends the next decade with functioning native kidneys or tethered to a hemodialysis machine.
To conclude our analysis, we want to leave you with a complex, forward-looking question that builds directly on the source text we have analyzed today.
With our rapidly growing understanding of immune heterogeneity and the precise laboratory-confirmed discovery of distinct inflammatory endotypes like Th1 versus Th2 responses in acute interstitial nephritis, are we rapidly approaching an era where the umbrella term acute interstitial nephritis becomes clinically obsolete?
As we move aggressively toward precision medicine, it prompts us to genuinely wonder if our current, antiquated, one-size-fits-all approach of utilizing broad-spectrum corticosteroids will soon be entirely replaced by highly targeted biologic therapies, meticulously tailored to the specific cellular pathway driving an individual patient's interstitial inflammation.
Thank you for joining us for this deep dive into the source material. Your dedication to evolving your clinical practice directly alters the trajectory of your patients' lives.